This program is brought to you by Emory University.
Good morning, everyone, and welcome to our first Heart and Vascular Grand Rounds. Hope everybody had a nice summer. So today it's my pleasure to introduce two of our own faculty members, Patrick Gleason. Dr. Gleason completed his cardiology fellowship here at Emory, and we were just saying it's been 6 years since he's been on faculty. He started the cardiac CT program at Emory Midtown shortly after he joined and has expanded his role for cardiac imaging to a co-chair Cardiac Imaging Council, a very important venture with radiology to help improve cardiac imaging across Emory Healthcare for nuclear, cardiac CT, and cardiac MRI. Dr. Gleason's always available to answer any of my questions related to imaging. And we know that he's critical in terms of teaching fellows and fellows education related to imaging, and leads the structural imaging program as well. And then he's joined by Dr. Michael McDaniel, who completed his residency in cardiology fellowship and interventional cardiology fellowship here at Emory as well, before joining faculty. He's an associate professor in the Division of Cardiology, serves as the director of cardiac cath lab and chief of Emory Cardiology at Grady Hospital. Dr. McDaniel is an interventional cardiologist with clinical interests in diagnosis and treatment of ACS patients and pulmonary embolism. He is actively involved in many international, sort of national organizations, including the Performance Question Writing Committee and ACC guidelines for management of PE. Without further ado, I'm really looking forward to this talk. When Patrick said he wanted to volunteer to talk about cardiac CT and controversies, I thought at first that they were going to debate each other, but I'm finding out that they're on the same team and on the same boat. So I'll turn it over to you, Patrick.
Thank you, Pooja, and good morning, everyone. Thank you for joining. So yeah, Dr. McDaniel and I have been talking for a couple years about trying to put together a cardiac CT grand round. So happy that we can speak today. I'm going to be covering kind of the asymptomatic patient and screening, risk classification, and Dr. McDaniel is going to be talking about the approach to the symptomatic patient in both the outpatient and inpatient setting. And then we're going to touch a little bit on some future cardiac CT technologies and some future pathways, even maybe for intervention. So no disclosures here. So I want to start with just making sure that we're on the same page about nomenclature and what we're going to be talking about here. So on the left here, we have a coronary artery calcium scan. That is a gated scan that we use a single phase of the cardiac cycle. So very low radiation, 0.5 millisievert to about 1 millisievert, which is less than your background radiation here in Georgia and Atlanta. There is no contrast that is used on a calcium score, and we just get calcium quantification only. There is no information that we get about non-calcified plaque and no information that we get about luminal stenosis. We end up getting a coronary artery calcium score, and the way that we do that is that there are computer programs that based on the size and density of the plaques get assigned a unitless score. We call it Agatston score, and that we then put into a percentile against similar patients. On the other side, we have a coronary CTA or a CCTA. That too is a gated exam, although we use a larger range of the cardiac cycle. So more like 3 to 5 millisieverts for a normal body habitus person. That would obviously increase the larger patients we get. That you get a total plaque assessment. So calcified and non-calcified plaque, as well as luminal stenosis there. So as we think about, we're both going to be talking about risk assessment. I'm going to be talking about it in the terms of primary prevention, right? How do we think about those individuals that have not had an event or presenting with acute chest pain syndromes? Whereas Dr. McDaniel is going to be talking about risk assessment in those, once they start with chest pain. So, for cardiology, obviously we use the majority, use the pooled cohort equation, and that gives us a 10-year ASCVD risk. And that's based on traditional risk factors like the ones you see here. And we use those to categorize people into low, intermediate, or high risk, and then assign whether or not we should start statin therapy or not. And the question that I want you to think about as we go through this talk is, do we think about the risk of future MI? Is that based really on the risk factors, or are we basing that decision on whether or not there is actually presence of coronary atherosclerosis? And what I hope to convince you of is that the quantification of coronary atherosclerosis is a superior predictor of cardiovascular disease risk compared to risk scores. And if we think about correlates in other medical subspecialties, maybe you or you've recommended things like colonoscopies or mammograms, where we actually go looking for the disease that we're trying to combat, and not just look at risk factors. And so I think start off with just where do the guidelines sit on imaging and screening? So this is from the latest 2018 cholesterol guidelines and prevention guidelines. So their recommendation as it stands right now is for those that are at low, intermediate, or intermediate risk, so individuals with a 10-year ASCVD between 5 and 20%, that if you add coronary artery calcium scoring, that you can kind of differentiate the patients that would then be at low risk or truly at intermediate risk. So if we look here at the low risk individuals, this is from the MESA cohort of individuals that were not on statin therapy, that the truly low risk patients, that the calcium score doesn't move the needle that much, and in the really high risk patients also doesn't move the needle. Whereas in this intermediate or low intermediate class, a calcium score will drop you below that 5% threshold for statin recommendation, and a positive calcium score will then get you to that near that 7.5 or above mark there. So I guess the question is, are we good at predicting who has coronary artery calcification or coronary atherosclerosis? And so this again is another study that looked at some of the MESA patients not on statin, and looked at first a couple of things. Number one is, can we tell who's going to have coronary artery calcification from the number of lipid abnormalities that they have, right? So looking at LDLs, HDLs, triglycerides, total cholesterol, and across the number of lipid abnormalities, there seems to be a pretty consistent, but certainly not increasing trend with the coronary artery calcification depending on the number of lipid abnormalities. They also looked at kind of a range of low to kind of intermediately elevated LDL cholesterol, less than 70 here, going up to above 130, and the incidence of events here on this y-axis. And what you can see is that the risk of events didn't seem to correlate as much with the level of LDL as it does with the amount of coronary artery calcium that these individuals have. And across the different levels of LDL, that we see that there is actually pretty consistent, event rates that is kind of tied to the coronary artery calcium, and not necessarily to the different quartiles there of LDL. And so maybe you're not moved by an LDL of greater than 130, and that certainly would be very reasonable. Some familiar names here. Also, Dr. Sperling, Dr. Sandacera, they looked at individuals within the MESA cohort with an LDL of greater than 190, which I think all of us would certainly think would be a very high risk group. And what they found was similar to what I just showed on the previous slide, is that their 10-year risk of events very low if they had a calcium score of 0, would actually fall below that 5% threshold. And a calcium score of greater than 0 is where all the events are. And you can see the kind of stepwise trend here from calcium score of 0 to calcium score of 1 to 100, and then greater than 100 here. So I think, again, kind of reiterating that the calcium is the risk, or the atherosclerosis is the risk. Now, what about the highest risk individuals, those with familial hypercholesterolemia? This is out of a clinic in Brazil, 206 patients, baseline LDLs of almost 270, so extremely elevated. I think we'd all agree with that. And in this cohort of patients, no MACE events seen with a calcium score of 0. And again, this kind of stepwise, at least initially stepwise, increase in the number of events with a calcium score of greater than 100 compared to 1 to 100. Well, LDL is certainly not the only thing that we look at and that we consider. I think it's everything that certainly what we probably maybe consider maybe the most important, but there are certainly other risk factors. And so, this is another study looking at 44,000 patients in a multi-registry kind of cohort. And so if you look here, they took into account kind of traditional risk factors here, those being things like smoking, hypertension, diabetes. And if you have, so if we look at the different presence of coronary artery calcium across these different groups here. So you can see that even in our zero risk factor group, that a third of patients have coronary artery calcification present, and some of them have a lot of coronary artery calcium. And similarly, even in those with 3 risk factors, while the majority of them, and we see a stepwise increase in the burden of coronary artery calcium, that a third of these patients are free of coronary artery calcium. And what they showed was that in those individuals with 0 risk factors and a calcium of greater than 400, those individuals had a higher mortality than those with 3 risk factors and a calcium score of 0. And I think, again, if you look across the different risk factor profiles here, you see an increasing incidence of events with increasing calcium, and with the calcium score of 0, that we remain at very low incidence rates. So going back just to looking at ASCVD risk in and of itself and how good of a predictor that is against coronary artery calcium, another study here looking at that MESA cohort. And if they had a predicted 10-year ASCVD risk, so if we look at the lowest risk individuals, less than 5%, if they had a calcium score of greater than 100, their event rate was 9.6 per 1,000 person years. And if their predicted risk was over 7.5% and they had a calcium score of 0, their event rate dropped to 2.4%. So seems to be a very powerful predictor, and showing that I think that we need to go looking to make sure that even in patients that we think are maybe low risk or even high risk, where are they in terms of their atherosclerosis burden? Can we use the calcium score to de-escalate therapy? So, there has been no randomized control trial to test calcium score and outcomes, but here's a large cohort of patients from Walter Reed, 13,000. And what they found here is that those individuals with a calcium score of 0, no difference in their mortality, whether or not they were on a statin or not. I think reaffirming here always is that we have those individuals with a calcium score of greater than 100 and greater than 400, very significant divergent curves here with those individuals that were on statin therapy, and dropping the number needed to treat down from 100, even at this low level. There was an improvement on statin therapy with individuals between a calcium score of 1 and 100, but certainly the biggest benefit for those individuals with a calcium score of over 100. And so the flip side question to that is, should we use calcium scoring to intensify our medical therapy? And so there's a couple of different, again, cohort studies, observational studies that look at this. So this is a study by Matt Budoff, 4,500 patients. This was something called the CONFIRM registry. It's a multinational registry. And what they found was that if you had a calcium score of greater than 300, that their kind of rate of events was similar to those individuals with a prior ASCVD event. Similarly, this study was using the Calcium Consortium. That's a multi-institutional registry, 20,000 patients. And what they found was that if those individuals with calcium scores of 700 to 800 had similar risk to those individuals in the PCSK9 inhibitor trials. So do we use these to add aspirin? Do we use those things to add, single P2Y12 inhibitors, or to add our PCSK9? Do we see those as the highest risk individuals, and to get very aggressive with their LDL lowering. So I just spent the last few minutes telling you about the importance of coronary artery calcium scoring, and I think it is certainly a very important and useful tool for us. Maybe the best part about it is it's very easy for our patients to get. It's very cheap. Emory charges about $100 for these tests total. But when is it not enough? As I talked about before, the CCTA gives us information about calcified and non-calcified plaque. And so if we look at these, predicted event rates here in the calcium score of 0 across the MESA cohort with these ASCVD risk, can we get that lower? And does coronary CCTA do that for us? So, as we had said before, what do we find when we look at this? So here's a patient, and I think what this shows, what these two patients kind of illustrate for us, is that even across the different calcium scoring thresholds, the non-calcified plaque is certainly very important to monitor and to note. So I'm not going to go into high-risk plaque features, but Dr. McDaniel is going to talk a little bit about that. But suffice it to say that these non-calcified plaque, or these low attenuation plaques, are the ones that are the highest risk. And so whether or not you have a lot of coronary artery calcium, we see that we have these non-calcified plaques here in the LAD, or in individuals with very low coronary artery calcium. This was a 44-year-old individual with obviously some pretty significant atherosclerosis here, that a coronary CTA can add a lot to this. And so there's not a lot of data behind screening, in asymptomatic patients with coronary CCTA. But, what we do have is very affirming that when you have no calcified and no non-calcified plaque, that your event rates, even in very high-risk individuals, is very low. This is a smallish study, 2,000 patients, with obviously very, very low event rates in individuals with a normal CCTA. So if we look even down here at the individuals with diabetes, which I think we'd all agree we'd think are very high-risk individuals, if they don't develop coronary atherosclerosis and they have normal CCTA, then they have very, very low event rates over the next 5 to 10 years, which I think is important in terms of how we risk stratify these patients and the intensity of therapy. Similarly, across different strata of individuals with risk scoring, it doesn't matter high, intermediate, low risk. If you have a normal CCTA, you just don't have the substrate to have events in the future. Certainly can't predict things like embolic MIs and myocarditis, things like that. But as far as atherogenesis, those individuals just don't seem to have events. And so, right now, I think that the future of screening for a lot of individuals, my personal bias is that we'll go in the direction of CCTA. Now, one of the things that I think is going to be an important leap, we have had the ability to do some coronary plaque assessment and quantification. Until recently, this has been really limited to research studies. When you get a report back right now, it's very qualitative. We say there's calcified, there's non-calcified plaque. We may say that there's some high-risk features, but we don't really quantify how much there is of each type of plaque and what the total plaque volume is. There's 2 companies out right now that offer this. It is not paid for by commercial insurance or Medicare. But so here is HeartFlow. This is on the left. This is, you may recognize this name. This is the company that does CTFFR, which, just as a plug, we have CTFFR now at all the different campuses that perform CCTA. So this company, we are actually in discussions and contracts with HeartFlow to get automated plaque analysis. And what you can see they are able to do is they segment out each of the vessels, and they give you an actual quantification of how much total calcified, non-calcified plaque. And then you'll see this low attenuation plaque up here. That we think is the highest risk plaque there. There is another company called Clearly that offers a similar product. And So I think that the next question that is a very reasonable question to ask is, well, what do we do with this information? Certainly no data out there right now with what to do with this. I think that there's a lot of, expert opinion and anecdotal information about, when should you intensify therapy. But, I think pretty soon we should have some answers. Emory has been asked to be part of the Transform trial. The Transform trial is the trial that Clearly is putting on. HeartFlow has their own separate trial. But this is going to be a very interesting study and a very important one, I think, for looking at, do these screening methods actually improve our outcomes? So this is going to be a prospective randomized trial. Asymptomatic individuals that we think are high risk, metabolic syndrome, prediabetes, and diabetes. Everyone in the trial is going to get a CCTA at the beginning of the trial, and then they're going to be randomized to risk factor-based care, so standard of care versus personalized care with the CCTA. So, based on your plaque burden, you're going to get put into a different stage, and then they're going to, give you therapy to target different LDL goals, as well as, again, intensification of therapy with either aspirin or P2Y12, and making sure that they're getting all the medications that they need. So there's going to be a centralized pharmacy that's going to provide all these medications. They've obviously got a number of partners for this trial. The Emory PI is out of family medicine. So if you know Ambar, please reach out to him. We have not gotten this off the ground yet. We were hoping to, when I initially signed up for this talk, I was going to use this as a advertising and recruitment effort. But unfortunately, we have not started yet. So reach out to him, ask him, and when I have more information, I certainly will relay that to you, because I think this is going to be very important. Individuals will get a repeat scan at 2 years, and obviously they're going to be monitoring important things like MACE. There are other health systems or places that are already doing this. So Lee Health is a health system down in Florida. Rick Chazal is a medical director there. He's a former ACC president and interventional cardiologist, and they are actually doing free employee screening with CCTA and then providing medications for free. They just started this program, really started screening people in 2022. They do not have any MACE data or event data yet, but they were able to convince the health system to do it, saying that they would reduce the amount of events, reduce the costs for the overall health system by missed work and reduction in paying for these cardiovascular events. So, I know of another system in New York that is about to undertake this, St. Francis. So I think you're going to see this more and more as we go. So a really quick word as to, the future of actually CCTA and where we're going and how this is going to improve as we go along. So long story short is the next kind of generation of CTs are called photon counting CTs. They skip a step in the processing and as a result give us ultra high resolution and really, as you can see in this example here, get incredible resolution and detail here you can see the stent struts here and stent restenosis. So this is coming. They are commercially available right now. We don't have one at Emory. If you know any philanthropists that would like to donate $3 million, would certainly be willing to talk to them. But hopefully in the next few years, Emory will get photon counting CT, and I think this will again kind of one step forward for screening and understanding of what is going on at the vessel level. So I'm going to finish up here and turn over to Dr. McDaniel for his piece of the talk.
Thank you so much. Really appreciate it, Patrick. That's awesome. Let's get this going. Okay, so I'm going to shift gears. I hope everybody can hear me. We're going to start talking about the symptomatic patients, and then we really want to make sure we have time at the end to finish up for some questions. So I'm going to start with the outpatients, the elective patients, the 68-year-old female, hypertension, dyslipidemia with 6 weeks of chest pain with exertion, 3 to 4 blocks, chest, pressure-like pain relieved with rest, EKGs unremarkable. And the question is, what's the next best step in this? And to do this, what we were all taught is that you need to start with pretest probability assessment. And so every cardiologist that's practiced for the last 40 years was taught some version of Diamond and Foster pretest probability. We were all taught that if you had typical angina and you were a middle-aged person with typical angina, that your risk was really high. Your pretest probability was so high that you really should, skip all diagnostic non-invasive testing, go straight to the cath lab because the probabilities of finding coronary disease are so high. We also know what's happened. If you look at what happens in the United States, when we go to the cath lab with elective patients, we find a lot of non-significant disease. 60% of all elective caths in the United States show no significant coronary artery disease. And so we have a very, very low yield. And part of this is probably the pretest probability assessment that we've been using. But fortunately, there's been a lot of data that's come out over the last decade or so that's really shown that Diamond and Foster way overestimates the probability of coronary disease based on the original tables, and the actually observed rates in practice are much lower than what we observed in the initial Diamond and Foster era, which was really published a long time ago. And so now both the ESC and the ACC guidelines have published updated pretest probability tables. And so this patient that we initially would have said would have had like 80% probability is actually much lower than what we would have thought. And so into the range where non-invasive testing is really preferred. In fact, if you look at the whole table, there really is no high pretest probability, at least based on tables anymore, in the ACC and ESC guidelines. So the real important updates in these guidelines is the acknowledgement that pretest probability has way overestimated the severity of coronary disease. So what is the next best step? Well, based on probabilities, you should probably start non-invasively, not invasively. And the question then is, what do you do? Is it ischemia testing or anatomy testing? And I'm going to spend the next few minutes really talking about the importance of anatomy and the downgrade of ischemia in its importance. We all know the story of ischemia, right? The more ischemia you have, the worse your outcomes. And so the hypothesis has always been that if we revascularize ischemia, that we will change the natural history and reverse these survival curves back to a normal. A very good hypothesis, very reasonable. It just hasn't turned out to be that way. We all know the ischemia trial that went out to test this hypothesis. They took patients with lots of ischemia. They randomized them to doing revascularization or just OMT. And what we all know is that in over 5,000 patients with moderate to severe ischemia, revascularization, the reduction of ischemia had no reduction on death, despite there being a pretty risk, a lot of risk patients in this, a lot of diabetics, LAD disease, and multivessel disease. And a lot of people said, well, we didn't get enough ischemia. We just needed to really focus on those severe ischemia. Lots of ischemia is really the problem. Well, even when they looked at the most ischemia patients, the severe ischemia, there was no survival benefit with revascularization. And we have now, actually we have more than this. This was published several years ago, 14 randomized trials, 15,000 patients, elective outpatients who have preserved LV functions, revascularization, mostly with PCI to reduce ischemia, does not reduce mortality across many trials, too many for us to go through. Now, the other big part in the ischemia trial is inherent in the design. The investigators set out to test ischemia. They knew they couldn't use nuclear stress testing to decide what to do. And they put a CT angiogram actually into the pathway. And the reason they did that is that you can't trust a positive test. So a positive stress test does not mean you have coronary disease. When you look at the PROMISE trial, which randomized CTA and ischemia testing, what they found is when you went to the cath lab based on ischemic testing, that it's 1 out of every 2 people do not have obstructive disease. So there's a very high false positive rate, or at least false positive in terms of finding obstructive disease, which is why you're going to the cath lab. And those rates can be dramatically reduced if you look at anatomy with coronary CTA. the flip side is also true. We need to know the left main patients and probably some of the multivessel disease patients to pick those patients out so that they're not ischemia trial type patients. And in the ischemia trial, 8% of the population had left main disease. And when they looked at the nuclear stress test findings, the nuclear stress test couldn't pick out those patients. There was no imaging parameters that independently associated with left main disease. TID, which we were always taught, is more common. Well, it was not more common in patients with left main disease. And I think the same would probably be true with three vessel disease. And the authors of the imaging sub-studies of the ischemia trial said to exclude left main disease, and probably the same would be three vessel disease, anatomic imaging is required. You just don't know what you have until you look. And we know balanced ischemia is real. You know, there's trials like this that look at patients with three vessel coronary disease on a cath, and they say, well, what did the spec show? And we know 1 out of every 5 patients with multivessel disease will have normal perfusion. You will miss it on a stress test if all you're looking at is perfusion, because you can have balanced ischemia. So when you look at pooled analyses of CT versus SPECT, CT is both more sensitive, coronary CTA, and more specific than ischemia testing. You can't rule in disease based on the presence of a positive test, and you can't rule out disease based on the negative test. And what's really interesting is the guidelines, the chest pain guidelines, give both strategies: an anatomic testing strategy as a class 1 and a stress testing strategy, mostly with SPECT, as a class 1. But it's really interesting to read it and to say, well, what are they saying? And so they say for patients that with stable chest pain and no known coronary disease. So this is a big caveat. These are all the patients who have never gone to the cath lab, never had a stent, never had a bypass. So you don't know what you're going to find. And so CTA, coronary CTA, can diagnose coronary disease. You can risk stratify the patient, as Patrick talked about, and you can guide treatment decisions. You can find out where the disease is, and you can make decisions about what to do for the patient. Nuclear testing for the same population is effective not for the diagnosis of coronary disease, but ischemia, and for estimating MACE, but not guiding treatment decisions. And that's because a positive study doesn't mean you have coronary disease, and a negative study doesn't mean you don't have disease. So anatomic testing is actually a diagnostic test where you can make decisions for your patients, whereas stress testing is a prognostic test, but you really don't know what you're treating until you get more information with an anatomic test. Now, from a prognostic standpoint, what's more important, ischemia or anatomy? And in the ischemia trial, it was the anatomy, that knowing the patient's disease, knowing if they have 3 vessels or 2 vessels or Prox disease, that these were way more important than knowing that they have some or a lot or even more ischemia. So anatomic seems to be a better even prognostic test than ischemic testing. Now, the silver lining of ischemia, as we all know, is that there was a benefit to revascularization in terms of symptomatic benefit. And that benefit was seen greatest in those that had the most severe symptoms. So if you had lots of angina, you got lots of benefit, but most patients had minimal or no angina. And so most patients got minimal to no benefit from revascularization. Now, the question was, the benefit that was seen, was this due to a placebo effect, or was this due to a true benefit of reducing ischemia? And that finally was answered in the Orbit-2 trial. We could spend a long time talking about these interesting sham-controlled trials, but just to briefly mention, it was 300 patients, stable angina, got randomized. They all had coronary disease and ischemia, and they got randomized to actually getting PCI or a pretend procedure, a sham procedure. They went to the cath lab, got sedated, and woke up thinking that they were revascularized. And what they did show was that PCI revascularization does improve symptoms above and beyond a placebo effect. And so that probably validates what we all did think. But the reason I show this is that in this Orbit-2 trial, they went back and they analyzed, well, how do you predict the patients that will derive that benefit? And what they found, the key findings of this, was that it's not ischemia and it's not the anatomy. Knowing that they have a lot of coronary disease or knowing that they have a lot of ischemia does not predict that they will benefit above and beyond a placebo effect. That what you need to know is, do they have actual angina, typical angina, Rose angina, that is the excellent predictors. And so that's one of the reasons that I love treadmills so much, and seeing objective evidence of people actually having exercise intolerance and exercise-induced angina, because that predicts a response to revascularization, not the fact that they have ischemia. And so I really like Bobby Ye's editorial comment to the Orbit 2 trial, and it's really profound. They say, our inability to address angina consistently with revascularization represents a limitation in our diagnostic acumen. We have no test that reliably identify a connection between patient symptoms and coronary anatomy. We had hoped ischemia testing would do that, but it does not. And that's why I love treadmills. But this is in line with a great quote from the original Orbita trial, in which they said clinicians have hoped that there might be this simple entity named ischemia, which manifests as a positive test in clinical symptoms, and that treatment with PCI would eliminate these manifestations concordantly. We had hoped that nuclear stress testing could be the gatekeeper to the cath lab. It would tell us the patients that needed to go on, and that would derive a benefit in the cath lab through revascularization, either for symptoms or MACE. But unfortunately, it's not the case. And so when you look at the updated revascularization guidelines for chronic CAD, there are really two indications. There are indications to improve symptoms, and then there are anatomic indications like left main disease and three vessel disease with low ejection fractions to improve survival. But ischemia is not an indication for revascularization. Having a lot of ischemia does not mean you need to go to the cath lab. It does not mean you'll get a benefit. It does not mean your symptoms get better. And it does not mean that you have survival indications. It's not an indication for chronic revascularization. So the gatekeeper really should be coronary CTA, and we now have randomized data that suggests this. The discharge trial is one of my favorite trials to talk about. They took 3,600 patients, and they said, all right, cardiologists, you guys send us your patients to the cath lab. And half of them went on for their elective caths, but the other half stopped by the CT scanner first. And if you went to the CT scanner first, you had similar MACE. In fact, there was no price to be paid by not going to the cath lab, and actually there was trends towards benefit. And what you found is, if you didn't go to the cath lab and you went to the CTA, that you could eliminate the need for a lot of caths for a lot of different reasons. And so you could eliminate caths up to about 80% in the elective setting. And not surprising, if you reduce procedures, you reduce procedural complications, and you also reduce costs. And so now we have 5 trials randomizing almost 6,000 patients in the elective setting, and they all show this similar trend, that about 77% of the diagnostic angiograms can be reduced with the use of coronary CTA. This reduces unnecessary revascularization. It reduces periprocedural complications like stroke, and it has similar mortality and MACE, and may even trend towards better outcomes. So back to our patient that we talked about with typical angina, we did a coronary CT angiogram first. It did confirm that the patient had severe LAD disease, and we'll talk a little bit about the type of plaque, this mixed plaque and soft plaque features, and there was mild disease in the RCA. We went on to cath the patient, and the invasive angiography confirmed what we saw on non-invasive angiography. There was mild disease in the RCA, and we placed a drug-eluting stent into the mid-LAD. So that's the outpatient elective setting. I'd like to shift gears real quick to the ED section, the acute chest pain. So the other big areas that we order lots of non-invasive is in the acute chest pain population and the CDU patients. And so let's shift gears to another example. A 45-year-old male, hypertension, dyslipidemia, comes in with chest pain to the emergency department. It's got a mix of atypical, typical features. EKG doesn't show much, gets a high sensitivity troponin. It's 12, and then gets repeated an hour later, 19. Now, Dr. Goyle and I talked about the use of high sensitivity troponin and risk stratification in acute chest pain before, so I won't go through any details of that other than to say that this is our Emory and Grady algorithms for the use of risk stratification and high sensitivity troponin testing, which is quite complicated. The bottom line is we use this to find the low-risk patients that go home without any testing, or the high-risk patients that get admitted to the hospital. But a lot of these patients, like the patient I described here, are intermediate. They end up kind of staying around, and most of these patients end up getting a observation admission in some sort of non-invasive testing. And the question is, what's the better test? Do we do anatomy or ischemia? And so I would argue that the data suggests that CT is really our test of choice in this population too. So we have 22 randomized trials. I'm not going to go through any of these in any detail. I'm just going to take the big picture highlights of this, of almost 10,000 patients looking at acute chest pain, the use of CT versus standard of care, which is mostly nuclear, but a mix of a lot of other ischemia testing. And bottom line is, when you use a CT, CT reduces length of stay because it's a faster test to perform. It also reduces cost. It's a cheaper test to perform in terms of it takes less personnel and less pharmacology and especially expensive radionuclide tracers. So it's a cheaper way to do this. And most of these patients are bundled in acute chest pain pathways. So there's no benefit to healthcare systems to spending more money in these scenarios. And in total, they lead to similar invasive angiography, although I would say that in more recent studies, this would probably be starting to trend towards CTA, but a lot of that depends upon how they're used. And again, there's no differences in hard outcomes like MI or mortality, especially in these low-risk patients in the ED. So in total, it seems like coronary CTA is a cheaper and better way to go about doing this, and provides value to our patients and to healthcare system. So what was the next best step for this? We thought it was coronary CT angiography, and the patient got this CT, had non-obstructive disease, and was sent home on the statin. So I want to finish up with just a quick comment about where we may be heading, and then really make sure we have some time at the end to open this up for discussion and questions. But this last patient was actually not a patient I saw. This patient here that had this LAD stenosis with no calcifications and positive remodeling here in the mid-LAD. This was actually a patient in this JACC article that went on several years later to have an acute coronary syndrome right at that location. And the question is, like Patrick was talking about, can we better risk stratify our patients for future events using anatomy like coronary CT? And so a couple things about this is really, we could talk a whole hour on, the vascular biology of acute coronary syndromes and what causes heart attacks. But we know that the vulnerable plaques that lead to acute coronary syndromes, they have some features that are similar. They're positively remodeled, they're inflamed, they have thin fibrous caps and a lot of lipid and big plaque burdens, and the calcifications are spotty or non-existent, but not dense calcifications. And so in this study that this patient was actually part of, it was 1,000 patients. They looked at the CT angiograms, and then they looked at what the features of the plaques were on the patients that went on to have future events. And they found that two big features stood out: having positive remodeling like this patient, and hypoechoic lipid-rich plaques. That those features suggested a future event rate that was much higher than not having those features. Now, we have several other natural history studies that kind of go in this same line. One of the most important was the Prospect trial. They looked at virtual histology intravascular ultrasound, which is a technology I'm not going to go into here. But again, they did IVUS of all the non-culprit lesions of patients who presented with acute coronary syndromes. And if your non-culprit vessels had thin caps with lipid-rich plaque with big plaque burdens and small lumens, that the event rates were up to about 20% over the subsequent few years in those patients. This was seen also in patients in the Prospect 2 trial, a little bit larger trial, very similar design. They used a different technology. Instead of VH-IVUS, they used IVUS with near-infrared spectroscopy, which looks at the lipid signal. We won't talk about this technology or its use. The important part was that those patients that had lots of lipid and big plaques had event rates, up to closer to 15% in the follow-up period compared to those plaques that did not have those features. And then an OCT study that showed some similar findings. If you had small lumens, thin fibrous caps, lots of lipid with inflammation, that again, if you had those 4 features, you had about a 20% event rate over the follow-up period. So all of them kind of using different technologies, but showing a similar trend in the importance of anatomy in terms of predicting of future events. And what was really interesting, and I don't want to overemphasize this because it's one trial, but it's intriguing, is the PREVENT trial. And so this was presented at ACC and published in Lancet. And I think it's really interesting because it's sort of a paradigm change of the moving from treating ischemia to treating anatomy. And what they did in the PREVENT trial is they randomized patients with these vulnerable plaques to PCI or non-PCI. And in the PREVENT trial, they actually did FFR to prove they were non-ischemic. So there's no ischemia in these patients, in these lesions. And then they had to have at least 2 of the following. They had to have lipid-rich, thin cap fibroatheromas, small lumens, or big plaque burdens. And they got randomized. And in this trial, they used a hodgepodge of technology. They used BVS and drug-eluting stents that we currently use. And what they found, it was a positive trial, that they reduced event rates by stenting vulnerable plaques. And when you looked at the hardest outcomes, death from any cause, there was a strong trend. It wasn't statistically significant, that was moving in terms of reducing mortality with this. Now, a lot of caveats. Okay, one, this is underpowered for mortality. This is a hypothesis. It was not statistically significant, so don't want to put too much in that. Secondly, these event rates are really a modest reduction and not as high as you would have anticipated based on the natural history studies that I just showed. But what's interesting is when you get into this trial and you say, well, how did these patients really get in? I don't know that we really randomized the right population, that most of the patients had small lumens and big plaques, but actually only a minority of patients actually had lipid-rich thin cap fibroatheromas. So what if we had done this trial with a little bit more enriched patient population? We might see some better outcomes. The other point to it is that the technology that we used, BVS was used in this study, and without going into that story, we know that BVS has not turned out to be a good technology. So they had much higher event rate. But if you looked at those randomized to medical therapy versus medical therapy and the current contemporary stents, the outcomes were better. And so the hypothesis is, if you could do this trial again, enrich the population with better vulnerable plaques and use a better technology, maybe you would see the MACE outcomes that we're not seeing with treating ischemia. So in summary, and then I want to open it up to have comments and questions. The things I would say about the symptomatic patients are that updated pretest probability tables predict much lower rates of CAD than we were taught for the last 40 years. And most of our patients should not go directly to the cath lab for invasive angiography, and that we should probably use non-invasive testing, and that non-invasive test in the outpatient setting is coronary CTA. It really should be the gatekeeper to the cath lab. It has better sensitivity, better specificity, better cost compared to SPECT, and it reduces costs and complications compared to invasive angiography. And so before going to SPECT and invasive angiography, I would argue start with a CTA. And in your acute chest pain pathway patients and CDUs, CTA is probably the preferred test. It can reduce length of stays, especially as we start to move this even upstream from CDUs with some of the technology that Patrick was talking about. And I think it'll get better and better in terms of reducing length of stays, and it's certainly cheaper than a lot of the other alternatives. And I think in the future, we'll see, does revascularization based on anatomy improve outcomes? We need much more studies, but it's very intriguing. And so with that, I would say thank you, and then open it up to the group for questions and comments.
Thank you so much. That was amazing. Thank you, Dr. Gleason, Dr. McDaniel, for getting us started with our first grand rounds. And this is going to be a hard one to follow after you've set the bar. I'm going to open it up for questions. Go ahead and type it in the chat. If you raise your hand, I may miss it just because we have so many people have joined. While we're waiting for people, I know people have lots of questions. I'm going to start off with asking, can you talk about, so, a lot of times for pre-op evaluations for renal transplant and liver transplant, et cetera, we sort of do stress testing, just transplant evaluation. Well, I wanted to hear your thoughts about that, Dr. McDaniel. And then another question for Dr. Gleason was a history of prior bypass and coronary CT angiograms. I wanted to hear your comment on that.
Go ahead, Mike. You want to take the first?
Sure. Yeah. I mean, to start off, well, preoperative testing is a controversial topic in general, whether we really reduce event rates by doing preoperative testing, and especially with imaging and then cath and revascularization, that there's really a paucity of data that's improving outcomes. In a lot of patients, I would argue CT is probably a better way to go, because it probably gives you the anatomy that you're looking for. And that if you had left main disease or triple vessel disease, that maybe those would be a better way of risk stratifying this than ischemia testing. The transplant renal population is an interesting one. They're a difficult patient population because of the amount of calcification. And so there's a limitation, I think, of coronary CTA, especially in the end-stage renal disease population. Maybe future technologies will overcome those limitations. But right now, when you have a lot of wicked calcifications, you can end up with non-diagnostic studies. I'll let Patrick comment on sort of the pathways. There's a lot of discussion of whether you start with a calcium score, before you screen for CTs. And that's a controversial topic. Some people say if you have really high calcium scores, then just don't even move on to the CT angiogram, because you'll just get non-diagnostic. But this is, I think, an area of controversy and will evolve as the technology improves.
Yeah, and Pooja, question about CCTA and those with bypass. I think that there's a couple of things. I think it just depends on, when you're going in there. I think if you have a patient with prior bypass, you already know that they have coronary disease. And it depends on the question that you're trying to answer. If you know that they have angina, to Dr. McDaniel's point, right, and you've kind of proven that they have angina, a lot of times it's just really to help with the kind of understanding with going in before the cath where the maybe culprit lesions are. You'd be surprised by how many times we find that patients have had bypasses to vessels that have non-obstructive disease in them, right? And so those go down. It also reduces the kind of searching for the bypass grafts. We can tell very well and easily what grafts are open and what grafts are not open. In patients with really severe disease and really severe multivessel disease, and then the utility kind of goes down at that point, because it's hard to tell if there's one culprit vessel, that's causing the symptoms versus multiple. But I think it can simplify the procedure, and just that you can sometimes still differentiate, where the lesion may be.
Okay, great. Thank you. Okay, we have 4 questions, so maybe we'll go through them quickly here. So first one, Dr. Rab asks, patients are on their own getting serial coronary calcium scores. Is there any data to support it?
Yeah, so I think that most people would, this it depends on who you ask. I think that the only reason to get them is if you're going to change management, right? So if you think that an individual has a certain, let's say they have a calcium score of 50, you start them on a statin, and you wanted to see several years later if their calcium score was now 400 or something like that, and you were going to intensify medical therapy, and maybe add aspirin, then I think it would be reasonable. Outside of that, it's certainly not. In most cases, they do not recommend serial CCTA or coronary calcium screening, just in that once you've made the diagnosis of coronary atherosclerosis, then you're kind of set there. So, but I do think you can use it in terms of, again, if you're going to intensify therapy over time, then certainly reasonable to try to get serial scans. Definitely not on a yearly basis, and not even something that you want to do maybe even every other year. This would be, several years in between calcium scores.
Okay. At what level of CAC does it become impossible to see the lumen, and then you're stuck with PET or SPECT?
Yeah, so the old threshold that we would use for CT was very low, a calcium score of 400. Right now, the Society of Cardiac CT does not recommend any necessarily limit on that. We at Emory, we use at least at Midtown here, we use a threshold of 1,000 per vessel, or a total calcium of over 2,000. We at least counsel the patient and the referring provider that it may be non-diagnostic, at that point. Now, CTFFR will say, HeartFlow says that they have no calcium limit for providing a CTFFR. So we have sent them. I do think that the sensitivity and specificity is reduced, as the more calcium you get. So yeah, I would say in general, 1,000 per vessel or 2,000 total for the heart. I think we probably shy away from proceeding.
Okay, and then Dr. Taylor asks, what will it take for insurance to pay for calcium scores? They pay for mammograms and colonoscopies, and then comment on plaque characterization, because we get lipid core size and cap thickness. What about plaque erosion?
Yeah. So the second question is a very good one. I mean, I think that we need to, with some of these newer technologies with automated plaque analysis and how automated, I know AI is kind of a buzzword, but I do think that we'll start to understand better the characteristics and picking these things up. In the case of HeartFlow and clearly, hopefully when we get the HeartFlow contract finalized and we're able to do this at Emory, I think that we'll start to see some improvement in our diagnostic, tests with that. As far as what it'll take for insurers to pay for it, I think that, I think we've probably not done a very good job of conveying the importance of these things. And two, I think that, we don't have the randomized trial data. It may be that we skip, we end up skipping over calcium scores and we end up having data based on CCTA. So I think, it certainly makes sense, and something that I think we all agree should have been in the repertoire for a long time. But I think, unfortunately, we just don't have the data or the kind of lobbying for it.
Okay, Dr. Abdullah asks, how much trust do you put in your CT FFR? And if the FFR absolute value is negative, do you still report it as positive? If the delta ratio.
Yeah, and if the FFR absolute value is negative, so yeah, so if the absolute value is negative, then the vessel or that lesion is negative, even if there's a positive ratio. And I think that that's something, I guess, so I think that as a general point, I would say that if people listening right now, if they have issues where they've had maybe a certain read that's come back and they felt like that wasn't consistent with what they found, or if they feel like they're getting inconsistencies with the read, that's something that I certainly would like to know about. We obviously have a large system with multiple specialties and multiple readers and things, and we certainly want to create a consistent reporting and interpretation structure across Emory. So if people feel like there's inconsistencies, certainly let me know. But that, in that case, if the CTFFR is above 0.8, then that is a negative CTFFR. Doesn't matter what the change across the lesion is.
Okay, Dr. Niazi asks, should we be checking inflammatory markers? So for example, checking HSCRP along with CAC score.
That is a great question. I'm going to leave that. I don't know if Dr. Sperling is on. Pooja, what do you think? You maybe.
Well, I'll let Dr. Sperling, if he would like to come in. I know that at ESC, there was this study that came out looking at LPA, LDL, and CRP. And those are all sort of powerful predictors of risk. And so I use all of those, and especially in women for, inflammatory marker reasons. Go ahead, Dr. Sperling.
Yeah, first of all, Patrick and Michael, outstanding presentation. You have set the bar quite high for Grand Rounds this year. It's an interesting question. So clearly in research, in our Clinical Cardiovascular Research Institute, our biobank, in our biomarker risk panel, we use CRP, HSCRP. In clinical practice, a CRP is fairly non-specific. And if you measure it over time, it can wax and wane some. From a population standpoint, clearly inflammatory markers are markers of cardiovascular risk, and inflammation is central to the pathophysiology of atherosclerosis, initiation, progression, and acute events. Using it clinically can be a little tricky. So often I don't order it frequently in clinical practice, but we get patients sent to us all the time who have all kinds of things measured. CRP, really is a marker of metabolic risk, obesity. Women on HRT, their CRP will go up. But clearly the data on anti-inflammatory approaches are very provocative now. In colchicine, Lodoco, there are trials going on now looking at interleukin blockers. So I would say be a little cautious using it in clinical practice. And exercise is anti-inflammatory, a Mediterranean diet's anti-inflammatory. So of course we should approach our patients. Statins are anti-inflammatory. Many of the agents we use are anti-inflammatory. So I'm not negating the importance of inflammation and atherosclerosis, but I'm not a big, CRP and everybody fan.
Okay, thank you. Dr. Lisko has a comment. The ischemia trial did not mandate revasc in the areas of ischemia found on stress testing and enrolled individuals with a 5% low ischemic burden and EKG changes. Do you think that an algorithm of CTA first with selective use of FFR to target lesion-specific ischemia would be better against optimal medical therapy alone? And are we ever going to see that trial? Probably.
I mean, great question. Great questions. I don't know that we can answer that. I think that the trouble is proving that ischemic reduction is what is benefiting our patients, or is it the revascularization of the anatomic vulnerable plaques? And a lot of these things go hand in hand, so it's hard to separate them because sometimes the vulnerable plaques are ischemic. But the question is which one do you start with? And I think if we start with anatomy over ischemic testing, it's a better first approach. It's better value for our patients. It gives us more information. Will reduce the amount of ischemic testing, and will reduce the number of unnecessary heart catheterizations, which is a benefit to all of our patients.
Okay, two more quick comments. I know we're past time, so we'll stop after these last two. I would say this Dr. Mavromatis would say that even high CAC scores, there's valuable information from CCTA. So proceeding with that test is reasonable. Does Patrick or have any comment on that?
Michael can certainly comment on that.
Agreed. I mean, I think that there's added value. So, we're still trying to figure out which patients should you not do a CTA in, based on calcium. And it's not the score, it's the distribution, how dense it is. I think it's a tough thing for us to figure out. Maybe AI can help us with better screening and to do this in the future. But I think there's additive value of CT angiograms right now.
Okay. And any comments on the prevent or versus pooled cohort equation?
Pooja, what do you think?
Well, I think that including, chronic kidney disease and the whole cardiometabolic is definitely important. But I think that having the CAC information is probably going to be more powerful, just because then you actually have the, actual
Atherosclerotic burden.
atherosclerosis.
Yeah,
Yeah.
I agree.
But we'll see, because a lot of chronic kidney disease or even borderline CKD patients do have athero already. So
Yeah.
that's a great question. I'm sorry, in the interest of time, we should end here. You can see the comments there. Dr. Goyle says, great talk. Agreed. Can Emory Healthcare accommodate the increase of CCTA volumes, given your talk?
Yeah, I think we certainly can. I mean, we have to. I think it's important that we kind of move in this direction, and we need all of our sites to be able to accommodate these tests. So, I think if you're having problems
For the-
getting patients in, then I need to know about it, and we'll make adjustments as necessary.
Okay,
And for the
great.
fellows, this is the future. So you see where this is heading, and we need more young people interested in this.
All right. Dr. Sperling says that he serves on the AHACKM, the Cardio Kidney Metabolic and Prevent Writing Group, and he'll be giving medicine grand rounds on this topic. All right. Thank you, everyone, for joining, and I will see everyone next Monday. Have a great week, and remember that the Fellows Conference starts this Friday also. Take care.
The preceding program is copyrighted by Emory University.